Welcome to the Deep Dive. Today, we are plunging into a stack of your sources that focus on the incredibly vital, interconnected systems of the body. The respiratory and cardiovascular systems.
Yeah, think lungs, heart, blood vessels, the absolute essentials, keeping everything running.
Exactly.
And our mission with this deep dive really is to pull out the crucial insights from this study material you shared. We're looking at common conditions, how they're managed, specific interventions, medications.
And how these systems change over your lifetime.
Is it sort of a shortcut to understanding the core stuff, recognizing the body's cues, how treatments work, maybe some surprising bits too.
Okay, let's unpack this. Maybe starting with the air we breathe. Diving into the respiratory system first. The sources put a lot of focus on asthma. What are the key cues from the material?
Well, the classic ones are definitely there.
Yeah.
Cough, wheezing, shortness of breath, chest tightness. But, a key thing the sources mention is how wheezing progresses. It often starts when you breathe out, but as things get tighter, you might hear it when you breathe in too. And then if it gets really bad, the wheezing might actually stop.
Stop completely. That sounds counterintuitive. Worse.
It can be, yeah. It's sometimes called a silent chest. It might mean the airways are so blocked that very little air is moving at all, a really critical sign.
Wow, okay. So no wheezing can be a major warning. What about tools to actually measure breathing, like peak flow? The sources mention zones.
Absolutely. Peak flow measures how fast you can blow air out. The sources use that traffic light system based on your personal best. Green's good, 80-100%.
Means things are under control.
Right. Yellow is caution, 60-80%. That means you probably need some treatment adjustment. And red, well, that's under 50%, an emergency. Needs immediate action, like a rescue inhaler, maybe more.
And the technique is important, I gather.
Oh, definitely. It's a single, hard, fast blow. That's key to getting an accurate reading.
Okay, so you recognize it, you measure it. How do the sources describe managing it? Sounds like a step-by-step thing.
It really is a stepwise approach. The foundation, especially for long-term control, is tackling the inflammation. So inhaled corticosteroids, ICS, are usually first line to the most potent anti-inflammatories.
Like in those combination inhalers.
Exactly. Like Symbicort, which combines an ICS with a long-acting bronchodilator, Alabia. So you get inflammation control and sustained airway opening.
And then there are the quick relief options for when symptoms actually hit.
Yeah, the rescue inhalers. Those are short-acting beta-adrenergic agonists, SABAs like albuterol. They relax the airway muscles fast.
But there's a catch, right? Using them too often.
Huge catch. The sources really emphasize this. If you find yourself needing your SABA more and more, it's a major red flag. It means your long-term control isn't working properly. Your asthma isn't actually well managed.
So the rescue inhaler is kind of a warning system itself.
Got it.
Beyond ICS-LABA combos, what else for long-term?
Well, there are leukotriene antagonists, like Singulair, and anticholinergics, like ipratropium. Though the sources note ipratropium isn't usually the go-to for long-term asthma control, unlike maybe in COPD. Plus, it can cause dryness.
Okay. What about the really bad times, asthma attacks or exacerbations?
For those flare-ups, oral steroids like prednisone are often used. A short burst, they call it, to quickly knock down that intense inflammation.
But there are side effects, even short-term.
Yes, the sources mention potential issues like temporary blood sugar spikes, maybe mood changes, trouble sleeping. And long-term steroid use, which comes up more with other conditions perhaps, carries risks like muscle weakness. During an attack, you'd also see more SABA use, possibly systemic steroids, oxygen if needed.
And antibiotics.
Only if there's a clear sign of a bacterial infection driving the flare-up, not routine.
Okay. And there was a mention of theophylline needing careful monitoring.
Yeah, that one has a narrow therapeutic window, like 515 mg/ml. Too much can be toxic, so blood level monitoring is essential if it's used.
Makes sense. Beyond the meds, what about prevention?
Avoiding known triggers is huge. Dust, mold, smoke, especially secondhand pets, whatever sets you off. And having a personalized asthma action plan is vital, knowing exactly what to do based on your symptoms or peak flow.
And getting the medicine in correctly seems crucial. The sources talked about different inhaler types, PMDIs and DPIs.
Right, and they work differently. Dry powder inhalers, DPIs, need a strong, fast breath in to pull the medicine out. And you absolutely cannot exhale into it. After you load it, you'll blow the dose away.
Okay, so deep breath in for DPIs. What about the puffer kind, PMDIs?
Those need coordination. Shake it, breathe out fully, put the mouthpiece in place, then press the canister while you breathe in slowly and deeply. Hold your breath for about 10 seconds. Wait a minute between puffs if you need more than one.
Sounds tricky.
It can be. That's why spacers are often recommended for PMDIs. They make the timing less critical and help more medicine get to the lungs.
And a really specific point for inhaled steroids, like that Symbicort example.
Rinse your mouth with water and spit it out after using an ICS. This helps prevent oral thrush, which is a fungal infection, and of course, keep the mouthpiece clean.
Good tip. Okay, let's shift from asthma to COPD, chronic obstructive pulmonary disease. How do the sources say this differs, and what's the absolute #1 intervention?
COPD is different because it involves more permanent lung damage. You see chronic cough, sputum production, and difficulty breathing dyspnea that gets progressively worse over time and isn't fully reversible like asthma often is. And the single most critical intervention, hammered home in the sources.
Smoking cessation?
Absolutely. Smoking cessation, it causes 80–90% of cases, and stopping is the only thing proven to really slow down the disease progression.
So stopping smoking is paramount. What else helps prevent those dangerous flare-ups, the exacerbations?
Avoiding other lung irritants is important too. And vaccinations are key. Getting the pneumococcal, flu, and COVID shots helps prevent the infections that often trigger bad exacerbations. Also, techniques like controlled coughing and breathing, retraining, pursed lip breathing, diaphragmatic breathing can help manage symptoms day to day.
When someone with COPD does have an exacerbation, what's the general approach outlined?
It's usually about stepping up the bronchodilators, adding or increasing corticosteroids, either pills or IV, sometimes antibiotics if a bacterial infection seems likely, which is often the trigger, and supplemental oxygen.
Are there signs that mean someone needs to be hospitalized?
Yeah, the sources mention things like using accessory muscles like neck and shoulder muscles just to breathe, worsening cyanosis, that bluish tinge to the skin, or becoming less alert or confused. Those are serious signs.
And oxygen therapy in COPD, it needs careful handling sometimes, right? Especially for people who retain CO2.
It does. For some people with advanced COPD who chronically hold on to carbon dioxide, their main signal to breathe can actually become low oxygen levels, not high CO2. It's called the hypoxic drive.
So giving them too much oxygen could be bad.
It could potentially reduce their drive to breathe. So the goal is usually to keep their oxygen saturation a bit lower than normal, say around 90%, or a PO2 of 60 at rest. Oxygen is often started at low flow rates, like 1–2 liters per minute via nasal cannula, and they need to be monitored very closely.
It makes sense. What are other long-term strategies for COPD?
Pulmonary rehabilitation programs are really emphasized. They help improve exercise ability and just overall quality of life. And nutritional support, high-calorie, high-protein diets, because just breathing can burn a lot of calories, and it can be hard to eat when you're short of breath.
Okay, moving on to cystic fibrosis, CF. The sources paint this as quite different with a very specific hallmark characteristic.
Yeah, the defining feature is those incredibly thick, sticky secretions. It affects multiple systems, lungs, pancreas, GI tract, sweat glands.
And the sweat test is key for diagnosis.
Exactly. The sweat chloride test. A level of 60 millieql or more on 2 separate tests is considered diagnostic. They have excess salt in their sweat. In the lungs, this thick mucus causes plugs, leads to chronic infections, often with nasty bugs like Pseudomonas aeruginosa, and over time damages the airways, causing bronchiectasis.
And it's not just the lungs, you said.
No, far from it. The pancreas is often affected, leading to pancreatic insufficiency. This means they don't digest fat properly and need to take enzyme supplements with every single meal.
Which leads to nutritional problem.
Big time. Difficulty absorbing fat-soluble vitamins A, D, E, and K. Plus, CF-related diabetes and infertility are also common down the line.
So with all those issues, what are the main management goals according to the sources?
It's really multifaceted. Controlling those chronic lung infections is huge, often needing complex antibiotic regimens. Promoting airway clearance is critical using things like chest physiotherapy, CBT, vibrating vests, special breathing masks, PEP masks, and aggressive nutritional support, including those enzymes and vitamin supplements.
Are there specific meds for the mucus itself?
Yes. Medications like Dornase alpha can help thin the mucus, make it less viscous. Inhaled hypertonic saline can also help draw water into the airways to improve clearance. Bronchodilators are used too. And newer drugs called CFTR modulators actually target the underlying genetic defect for some patients.
Okay, another one mainly affecting the little ones, RSV, respiratory syncytial virus.
Right, mostly infants and toddlers under 2. Prematurity, other chronic health issues, being in crowded settings like daycare, exposure to secondhand smoke, those are risk factors.
And the symptoms can start mild but get serious fast?
Exactly. It often starts like a common cold runny nose, maybe a fever, cough.
Yeah.
but it can quickly progress, especially in infants, to severe respiratory distress. You might see signs like air hunger, retractions where the skin pulls in around the ribs with each breath, really fast breathing, maybe over 70 breaths a minute, cyanosis, even pauses in breathing, which are called apneic spells.
Is there prevention?
For high-risk infants, yes, there's pelivizumab, which is a monoclonal antibody given as monthly shots during RSV season. There's also an antiviral, ribavirin, though its use is more limited. And recently, a vaccine became available for adults over 60 to help protect infants they might be around.
What's the core nursing care for a baby with RSV?
A lot of it is supportive, but crucial. Using saline nose drops and then suctioning the nose to clear secretions, babies are nose breathers. Strict hand washing is vital to stop the spread. No smoke exposure, small frequent feeding so they don't get too tired. Humidify air might help. And really close monitoring for those danger signs. High respiratory rate, cyanosis, decreased breath sounds.
And isolation precautions.
Yes, contact and droplet precautions are needed in healthcare settings.
Okay, a very difficult topic next. SID, sudden infant death syndrome. The sources must put a huge emphasis on prevention here.
Overwhelmingly so. The absolute key message from the material is promoting safe sleep practices.
Which
Always place babies on their back to sleep for every sleep naps and nighttime. Use a firm, flat sleep surface like a mattress and a safety-approved crib or bassinet. And keep the sleep area totally clear. No pillows, no loose blankets or sheets, no stuffed animals, no bumper pads, no weighted sleep sacks, nothing but the baby in a fitted sheet.
So back is best and a bare crib are the main takeaways.
Absolutely essential. The sources also list risk factors like a previous SID's death in the family, low birth weight or prematurity, maternal smoking or substance use, secondhand smoke exposure, a recent minor illness, soft bedding, co-sleeping in an adult bed.
And interestingly, not using a pacifier or breastfeeding were listed as risks.
Yes, the sources indicate that pacifier use at sleep time and breastfeeding seem to have a protective effect. After a death, the sources highlight the nurse's role, allowing the family time with the infant, ensuring an autopsy is offered, which is important for confirming SIDs and ruling out other causes, providing immense emotional support and connecting the family with grief resources. It's an incredibly sensitive situation.
Let's zoom out a bit to overall oxygenation. What are the priority cues, the real red flags from the sources, that someone isn't getting enough oxygen? What's often the first sign?
The sources really point to agitation as often being the very first sign of hypoxia, a poor gas exchange, especially in adults, maybe even before the oxygen saturation number drops significantly.
So restlessness, anxiety.
Exactly. Other critical keys are confusion, low SpO2 readings, obviously, abnormal breath sounds or maybe no breath sounds, that silent chest, again, using those extra accessory muscles to breathe, and a fast respiratory rate.
And kids show it a bit differently.
Yeah, infants and small children might show things like belly breathing, really using their abdominal muscles and flaring their nostrils with each breath.
The sources also mention some specific abnormal breathing patterns.
Just briefly, yes. Kussmaul breathing, deep and rapid, often seen in things like diabetic ketoacidosis, where the body's trying to blow off acid. Jane-Stokes, that waxing and waning pattern, faster and deeper than slower and shallower, often seen near the end of life. And Biot's breathing, irregular clusters of breath followed by pauses, often linked to brainstem issues.
Are there simple things that can help immediately?
Definitely. Just elevating the head of the bed, maybe to 90 degrees if they can tolerate it, can make a difference. Encouraging deep breaths and coughing, or using an incentive spirometer to help keep the lungs open.
And how does breathing physiology change as we age based on the material?
It changes quite a bit. Infants and young kids have smaller, narrower airways, fewer air sacs, alveoli, so they're much more prone to obstruction and infections. Then as we get older, starting maybe around age 40, things gradually decline. The lungs lose some elasticity, the surface area for gas exchange decreases, respiratory muscles weaken, the chest wall gets stiffer.
Which increases risk for
things like aspiration, pneumonia, and just generally reduced breathing capacity.
Okay, let's completely switch gears now. Cardiovascular system. The heart, the vessels, the flow. To really get the conditions, we need some basics. What's cardiac output, according to the sources?
Cardiac output, or COO, is basically how much blood the heart pumps out each minute. The sources define it with that simple formula. Stroke volume, the amount pumped with each beat, times the heart rate.
Got it. And ejection fraction, EF.
That's the percentage of blood in the left ventricle that gets pumped out with each beat. Normal is around 55-65%. If it drops below, say, 45%, That's often a sign of heart failure.
And then preload and afterload, they sound technical. How did the sources explain them simply?
Think of preload as the stretch on the heart muscle fibers just before they contract. It's mostly about the volume of blood filling the ventricle. More fluid in your system generally means higher preload.
Okay, the filling pressure or volume. And afterload.
Afterload is the resistance the heart has to pump against to get the blood out. Think of it like the pressure in the aorta and arteries that the heart has to overcome. High blood pressure means higher afterload. That makes sense. Helps understand how things stress the heart, which leads us right into blood pressure itself. What are the key numbers and categories from the sources?
Right. BP is that force of blood on artery walls. Systolic is the top number, pressure during contraction. Diastolic is the bottom number, pressure during relaxation or filling. The sources use the standard ACCA categories. Normal is less than 1288.
Okay.
Elevated is 120, 129 systolic, and still less than 80 diastolic. Stage 1 hypertension is 130, 139 systolic, or 80, 89 diastolic. And stage 2 is 140 or higher systolic, or 90 or higher diastolic.
And you usually need more than one high reading.
Yeah, typically diagnosis requires at least 2 elevated readings on separate occasions.
Okay, so let's talk about hypertension itself, high blood pressure. What cues did the sources mention for recognizing it, and what's a key priority if someone's in a hypertensive crisis?
Well, hypertension is often silent, right? That's the danger. Symptoms might not appear until damage is already happening, so diagnosis relies on those BP readings. But physical exam might show clues, maybe changes in pulses, hearing abnormal sounds called bruits over arteries, or signs the heart muscle is working harder, like a displaced heartbeat or an extra sound called S4.
And labs.
Labs like BUN and creatinine are really important because high BP hammers the kidneys over time. If someone is in a hypertensive crisis that's severely high BP causing organ damage, the sources highlight that monitoring intake and output, like how much fluid goes in and how much urine comes out, becomes a critical priority, especially if they're getting IV meds to bring the pressure down quickly.
Education seems huge for hypertension. It's about managing it long term. What are the key lifestyle things the sources push?
Lifestyle changes are absolutely foundational. The DAH diet comes up. Dietary approaches to stop hypertension. Big focus on reducing sodium intake. Weight loss, if needed, aiming for that healthy BMI range of 18.5 to 24.9. Regular exercise, like 30 minutes most days. Limiting alcohol. And a huge one, avoiding all tobacco and nicotine. Stress reduction techniques, too.
And sticking with medications is crucial.
Absolutely. It's about controlling BP, not curing it. Patients need to understand they can't just stop their meds, or they risk rebound hypertension where the pressure shoots back up. Home monitoring helps track progress. Regular checkups are needed to monitor for target organ damage, like checking the eyes for retinal changes.
Okay, let's talk meds. The sources covered several classes. Can you walk us through the main ones and key monitoring points?
Sure. Diuretics are often a starting point. Thiazides like hydrochlorothiazide, HCTZ, are common first-line choices. They help flush out excess salt and water. The big thing to monitor here is electrolytes, especially potassium. Thiazides can make you lose potassium, leading to hypokalemia.
And loop diuretics, like furosemide.
Loops like furosemide or bumetanide are more potent, work faster, but don't last as long. They also cause electrolyte loss, especially potassium, so monitoring is vital. Plus, watch for dehydration.
Then there are ACE inhibitors, the EPROLs.
Right, like lisinopril. They work by relaxing blood vessels, lowering resistance. A really common side effect the sources mention is that nagging, dry cough. They can also increase potassium levels, hyperkalemia, so you monitor potassium along with sodium and kidney function, like creatinine and urine output. And there's a rare but serious risk of angioedema swelling, usually of the face and airways.
And ARBs, the triptyline.
Angiotensin II. Receptor blockers, like losartan. They work similarly to ACE inhibitors, but are much less likely to cause that cough. Same monitoring for potassium and kidney function generally applies.
Calcium channel blockers, CCBs.
Like the sridipines, amlodipine, or others like diltiazem and verapamil. They relax blood vessels, too. Some also slow the heart rate and reduce how hard the heart contracts. So side effects can include low blood pressure, slow heart rate, sometimes constipation.
And finally, beta blockers, the lulls.
Metoprolol and atenolol are common examples. They decrease heart rate, reduce the force of contraction, and slow conduction through the heart. A really critical point from the sources. Don't give them if the systolic BP is below 90 or the heart rate is below 60. Patients should never stop them abruptly, risk of rebound issues. And they can mask the warning signs of low blood sugar, which is important for people with diabetes.
Wow, lots to track.
Oh.
Okay, shifting to acute cardiac events. Acute coronary syndrome, ACS, which includes heart attacks, MI, what's the absolute priority?
Recognizing the symptoms and acting fast, that's the priority.
Hmm.
The classic symptom is that severe chest pressure or pain, maybe radiating to the arm, jaw, back. But it can also be nausea, dizziness, shortness of breath, sweating. Women might have less typical symptoms sometimes.
And immediate interventions.
The goal is to relieve pain, reduce the heart's oxygen demand, improve blood flow, and prevent more damage. The sources mention the OA&M mnemonic sometimes. Oxygen, aspirin, chewed for faster absorption, nitroglycerin, under the tongue or spray to dilate vessels, and morphine for pain relief, which also helps reduce cardiac workload. Time is muscle.
Definitely. Okay, let's talk blood clots. Deep vein thrombosis, DVT. What puts someone at risk? The sources mentioned Virchow's triad.
Right. Virchow's triad is a classic way to think about the three main factors contributing to clot formation. First is changes in blood flow or stasis. Think being immobile after surgery, long flights, heart failure.
Okay, blood pooling.
Second is damage to the blood vessel wall, endothelial injury. This could be from trauma, surgery, inflammation, even IV lines.
Makes sense.
And third is hypercoagulability, meaning the blood itself is more prone to clotting. This can be from inherited disorders, certain medications like birth control pills or hormone therapy, cancer, pregnancy, dehydration, or even suddenly stopping anticoagulants. Age over 40 and things like recent COVID infection also increase risk.
How is DVT managed? There's prevention and treatment, right?
Exactly. Prevention, especially in hospitalized or post-op patients, involves things like getting people moving early, leg exercises, compression stockings, or those sequential compression devices, SCDs. Lifestyle stuff like weight management and not smoking helps too. Medication-wise, prophylactic doses of anticoagulants like low molecular weight heparin and oxypirin or subcutaneous unfractionated heparin are common.
And if someone has a DVT?
Then the goal is treatment with anticoagulants to prevent the clot from getting bigger and to stop new ones from forming. It's crucial to understand, as the sources state, these drugs don't dissolve the existing clot. The body breaks that down over time.
And monitoring these anticoagulants is key. Heparin versus warfarin.
Yes. For heparin, usually given IV for treatment, you monitor the PDT or APTT. The therapeutic goal is typically 1.5 to 2.5 times the normal control value. Need to watch for HIT, heparin-induced thrombocytopenia. The reversal agent is protamine sulfate.
And warfarin.
Warfarin, Coumadin, is the oral one. It takes several days, maybe 3 to 5, to reach its full effect, so patients are often started on heparin and warfarin together, called bridging, until the warfarin kicks in. For warfarin, you monitor the PT and INR. The target INR for DVT is usually 2.0 to 3.0. Vitamin K is the antidote.
What about enoxaparin? That's Lovenox.
Yeah, enoxaparin is a low molecular weight heparin given subcutaneously. It has more predictable effects, often doesn't require routine lab monitoring like heparin or warfarin. The sources emphasize not rubbing the injection site afterwards, as it can increase bruising. Clopidogrel, Plavix, is different. It's an antiplatelet, affects platelet function, so you'd monitor platelet counts.
When assessing someone you suspect has a DVT, what's the priority?
Priority is looking for those signs. Unilateral swelling, one leg bigger than the other, warmth, redness, tenderness, pain. Measuring the calf circumference of both legs and comparing is a key nursing intervention mentioned.
And that Homan sign.
The sources specifically say don't do it. Forcing the foot upward to check for calf pain is unreliable, and worse, it could potentially dislodge the clot. Not recommended. Elevating the affected leg and encouraging gentle movement as prescribed are better interventions.
And the big worry, the major complication of DVT.
Pulmonary embolism, PE. A clot breaking loose and traveling to the lungs.
Which the sources label a medical emergency.
Absolutely. It can block blood flow in the pulmonary artery, which can be fatal. The most common symptom reported is sudden onset shortness of breath, dyspnea, and the most frequent sign is rapid breathing, tachypnea.
Okay, let's quickly touch on peripheral vascular disease, PVD. How does this differ from DVT, and what are the main risks and cues?
PVD is broader, usually referring to problems with blood flow in arteries or veins outside the heart and brain, often in the legs. The main cause the sources point to is atherosclerosis, that plaque buildup narrowing the arteries, also called peripheral artery disease, or PA.
And the risk factors. Sound familiar?
Very familiar. Smoking is a huge one for PA. High blood pressure, high cholesterol, diabetes, obesity, inactivity, the usual cardiovascular culprits. The classic symptom is intermittent claudication, muscle pain or cramping, usually in the calves, that comes on with walking or exercise and goes away with rest.
It happens because the narrowed arteries can't deliver enough oxygenated blood to the muscles during activity.
What else might you see? Physical signs?
Signs of poor blood flow or ischemia. The skin might be cool, pale, thin, shiny. Hair loss on the lower legs and feet. Nails might get brittle. You might see dependent rubor. The foot gets reddish-purple when hanging down, but pale when elevated. Pulses in the feet might be weak or absent. In severe cases, you can get painful ulcers, often on the toes or foot, or even gangrene.
The sources also mention aneurysms and venous insufficiency.
Briefly, yes. Aneurysms are bulges in arteries, like an abdominal aortic aneurysm, TRAL-OA, where you might feel a pulsating mass in the abdomen. Chronic venous insufficiency is a vein problem. Faulty valves let blood pool in the legs, causing swelling, skin discoloration, often brownish, and ulcers, usually around the ankles. Raynaud's is different again, episodic spasms of small arteries, usually in fingers and toes, triggered by cold or stress.
What's the management focus for PVDPA?
Aggressive risk factor modification is number one. Stop smoking. Control blood pressure and cholesterol. Manage diabetes meticulously. Medications like silestazol might help with claudication symptoms, but the sources note it's contraindicated in heart failure. Education on foot care is critical, inspecting feet daily, avoiding injury, proper footwear. Exercise programs like walking until pain occurs, resting, then walking again, can actually help build collateral circulation over time.
And specific nursing points, say, after an AAA repair.
Post-op AAA repair. Keep the patient relatively flat initially. Monitor peripheral pulses very carefully. Check the access site for bleeding. Manage fluids. Try to prevent straining, no heavy coughing, sneezing. And report high blood pressure, like SBP 180, immediately. For venous insufficiency, leg elevation, compression therapy, and wound care are the mainstays. It's all about managing perfusion and preventing complications.
Okay, let's wrap the systems together with lifespan considerations.
Genetics definitely play a role in heart health. In babies, fetal circulation pathways like the foramen ovale and ductus arteriosus are unique. DVT is less common in kids, but can happen, often linked to genetic factors or central lines. In teens and young adults, contraceptives or surgery become more relevant DVT risks.
And pregnancy.
Pregnancy significantly increases DVT risk due to hormonal changes, making blood clot easier and the uterus pressing on veins. DVT generally becomes more common after age 40. In older adults experience those age-related cardiovascular changes, stiffer arteries, maybe less efficient heart muscle function.
Okay, let's tie this all together with some key labs and management techniques the sources highlighted. For respiratory, what are the main diagnostic labs?
Arterial blood gases, ABGs, are crucial for assessing oxygen, PO2, carbon dioxide, PO2, and acid-base status, pH, bicarb. Pulse oximetry, SpO2, gives that quick oxygen saturation check. Pulmonary function tests, PFTs, especially looking at FeVO1-FVC ratio, help diagnose obstructive diseases like asthma and COPD. Chest X-ray or CT scans show structural changes or infiltrates. CBC can show infection, WBCs or allergic components, eosinophils. Allergy testing for asthma triggers, and that alpha-1 antitrypsin level for potential deficiency.
And CF specific.
The sweat chloride test, needing that OFE60ABQL result twice. Stool test for fat malabsorption or enzyme levels.
Switching to cardiac labs, what's essential?
For diagnosing heart attack, MI, troponin is the most specific biomarker according to the sources. It rises when there's heart muscle damage. Other general labs like creatinine, kidney function, very relevant in hypertension, cholesterol levels, and glucose are important for overall risk and management. For hypertension, checking BUN and creatinine regularly tracks kidney impact.
And for clots, DVT-PE beyond imaging, coagulation labs seem central.
Hugely important. D-dimer can help rule out a clot if negative, but it's not specific if positive. The key labs are for monitoring therapy. Platelet count, watching for HIT with heparin or with antiplatelets like clopidogrel. PT and INR for warfarin, target INR usually 2.0, 3.0. PTT or APTT for heparin, target usually 1.5, 2.5 times control.
Translating those labs into action, what's the absolute must-monitor point when patients are on anticoagulants? This seems like a major focus.
It's the major nursing priority, highlighted repeatedly. Yes, you monitor the labs, PT-INR, PTT, to make sure the dose is right. But the most critical thing is constantly watching the patient for any signs of abnormal bleeding.
Like what specifically?
Black, tarry stools, melena, blood in urine, hematuria, unusual bruising, nosebleeds, bleeding gums, severe headaches, dizziness, changes in mental status, could signal brain bleed, unexplained drops in blood pressure. Any of these need immediate reporting. Remember, vitamin K reverses warfarin, protamine reverses heparin.
What about monitoring with diuretics or ACE inhibitors?
For diuretics like HTTZ or furosemide, it's all about electrolytes. Monitor potassium closely,
risk of hypoclemia, sodium, magnesium, sometimes calcium. Check blood glucose too, especially in diabetics. Watch for symptoms the patient reports, like muscle cramps or weakness. For ACE inhibitors like lisinopril, monitor potassium, risk of hyperkalemia, sodium, and kidney function. Creatinine urine output.
And quickly, chest tube management. Key nursing points from the sources.
Assess the drainage amount. Color. Check the water-sealed chamber for air leaks. Continuous bubbling usually means a leak somewhere in the system or from the patient. Keep the drainage system upright and below the level of the patient's chest. Have emergency supplies ready. Padded clamps, hemostats, petroleum gauze dressing, sterile water.
What if the tube accidentally comes out?
Immediately cover the site with an occlusive dressing, often taped on 3 sides to allow air to escape but not enter. Follow your facility's specific protocol.
Or if it disconnects from the drainage system.
Place the end of the chest tube into a bottle of sterile water immediately. This creates a temporary water seal and prevents air from getting sucked back into the chest cavity.
It really sounds like underlying all these specifics is that core nursing process.
Exactly. It's about taking all this information from the sources, recognizing cues like agitation or leg swelling, analyzing what they mean, prioritizing actions like giving oxygen or monitoring for bleeding, implementing the interventions correctly, and then evaluating if they worked. All these details slot into that framework.
Wow. We have covered a lot of ground here, journeying through the lungs and heart based on your sources. From asthma cues and COPD progression to CF's unique challenges and SIDS prevention.
Then crossing over to cardiac output, blood pressure management, recognizing ACS and DVT, understanding PVD, it's incredibly interconnected.
And seeing how things change across the lifespan, why certain interventions are done rinsing after inhalers, careful oxygen use, specific lab monitoring for meds, measuring legs but avoiding Homans, it really helps solidify the why.
Definitely. This deep dive shows how recognizing specific cues, understanding the interventions outlined in the material, all fits into that larger picture of health.
So here's something to mull over based on everything we've unpacked from your sources. How does this detailed understanding of these mechanisms, the specific cues, the interventions, maybe change how you think about observing or responding to respiratory or cardiovascular issues in practice, drawing directly on these insights?
Keep diving deeper.